please.
Thank you, Dr. Tal. Thank you so much for the organizers for inviting me. This is, it's amazing. I always learn so much from all these people that I look at as my mentors because they teach me so much every time. So thank you all for coming, and I'm going to talk about gene therapy of anterior segment diseases. I have no financial interests. So first let's start with what is gene therapy, right? We talk about it all the time, and basically if you look at it as a whole, it's delivering some sort of genetic material into targeted cells to correct some sort of a genetic or even acquired, and you'll see examples of both diseases in the cornea. So something different from the usual bacterial antiviral things that we do. And what are some of the things you can do with genetic material? So you can take a gene that's not working, for example, some of the gelatinous dystrophies where the gene is not doing what it's supposed to. You can silence the genes that are causing a problem, like some of the RP disorders, where you have a toxic reaction to the cells and the cells die. You can compensate for some of the ill effects. For example, you could deliver anti-VEGF to cells to make their own anti-VEGF instead of delivering from the outside. And then you can precisely edit some abnormal genes, as you'll see in some of my herpes work. So the reason I got involved with this is Dr. Houseworth, Bill Houseworth is one of my mentors. He was a faculty member when I started at the University of Florida. And he was working on gene therapy for several years before it became popular. What the dog you see is called Lancelot. He's a dog that was born with a form of LCA, so of Leber's, that makes these dogs blind. And he got injected with this gene therapy in one eye, and it was great to see this video of him going through a maze, and in the eye that he had vision or he got injected, he was avoiding the maze. And on the other side, he kept hitting the walls of the maze. And it was really, really exciting to see that. And then, of course, that drug became Luxturna, which we now use commercially, at least in the States. So we started looking at gene therapy for corneal diseases. And the problem is getting the genes to where you want it to go. And so some of the ways that you can do that is by iontophoresing, or you can inject it intrastromally, like I do for fungal ulcers all the time, which, again, I learned at this meeting. And then we use AAV vectors. So one of the things I was looking at was PTK or PRK, right? So when you do refractive surgery on the surface, you can get scarring, especially when you do a lot of astigmatism correction or deep correction. And it's caused by TGF-beta, which is transforming growth factor. It helps you heal, but it also causes scarring. And connective tissue growth factor is one of the downstream regulators, which causes the actual scarring. And so we were targeting that. And what we did was we created a protein that was the opposite. It was an antisense to the gene that causes scarring. And we iontophoresed it, and basically iontophoresis means you take an electric shock and you drive it into the cells. And so here you can see in this mouse, we've delivered it, and you can see here that you can see how that the fluorescein protein has gone deep into the cornea, and then you can see the entire cornea lights up because it's driven into the cornea and actually goes into the anterior chamber too. And you can see on histology how it gets into the various cells. And so this is a rabbit that has undergone a PTK, a phototherapeutic keratectomy. And again, we've put this antisense oligonucleotide into the cornea, and it heals up. And you can see on the left side a rabbit that got just an oligonucleotide to something completely unrelated. And on the right side, they got it to anti-CTGF. So it was targeting the CTGF, the connective tissue growth factor. And you can see a very interesting change in the amount of scarring. And here again, you can see on the top are all the scrambled oligonucleotides, and at the bottom are the ones that actually target CTGF, and the scarring is significantly reduced from that. So we know that we can reduce scarring by providing this protein. And then we started looking at, so one of the things that I'm interested in is herpes. So I was very interested in the last talk by Dr. Garg because I diagnose everything with herpes, right? Because it's you have an idea about something and you go for that. And so we were looking at that and how do we get something to, again, the herpes affects the cornea, but the problem is in the trigeminal ganglion. That's where it's sitting and it's reactivating. And so we used AAV, which is the same vector that Dr. Houseworth used for his LCA and RP studies. It's a very, very tiny virus. The good thing about the virus is it's so tiny that it can get into tissues easier. The problem is it's so tiny that you can't load it with a whole lot of genetic material. HSV and adenovirus are bigger viruses, but then it's harder for them to get in. And then lentivirus has been used clinically in cancer, as you guys all probably already know. The cornea, and the nice thing about AAV is that different varieties of AAV target different tissues. And so here you have AAV2 and 5, which tend to have a propensity for the corneal tissue. And so it actually, the 2 and the 5 get into different cells, but you can see how the endothelium is lit up. You can see the epithelium lights up, and a lot of the keratocytes light up with these vectors. And then what we used is a ribozyme, which is something you can make, custom make. And so you take the mRNA that you're interested in, and you make this ribozyme to match it, so it complements it. You remember your AGTC and then the opposite pairing up. And so you pair it up, and then the center portion, this little loop here, actually cuts the RNA. Once you cut an RNA, it becomes very unstable, and it breaks down, the cell eats it all up. And so you can use this to target mRNA that helps the virus make capsids and replicate itself. We gave it by an intrastromal injection into the cornea, and then it enters the nerve endings, and what we use is actually serotype 8, which has a propensity for neural tissue. And here you can see the trigeminal ganglion, and then this is the one that has the AAV vector that's gone into it. So AAV8 goes right into the trigeminal ganglion. And so these are rabbits that have HSV that has been latently infected, just like us when we get HSV. So it's sitting in the trigeminal ganglion, and we give them an iontophoresis of epinephrine to make it reactivate. The left side is a patient, is a rabbit again, that got one eye that had just the AAV vector without the ribozyme. On the right side, on your right side, is the one that got the ribozyme that kills the HSV. And when we reactivated the HSV, you can see that the left eye does not have HSV lesions, showing that it did actually suppress that, and we've shown that with histology too. There's some investigational drugs that are commercially now trying to be available, where you can inject AAV into the lacrimal gland, the thinking that you would then make it in the tear film, and you can make nerve growth factor for patients who have neurotrophic keratitis, and maybe use some enzymes that you produce yourself that break down histamine for vernal keratitis. So very interesting work that's being done on gene therapy everywhere. Thank you.
Thank you, Dr. Sonal. Something to think about for future. Just, do we have some clinical studies coming up?
So they're working on these enzymes, and we're actually starting on, thank you. I don't have a commercial interest yet because we don't have the company yet, but we are starting the HSV studies, hopefully clinically soon.
Thank you, thank you.
Do you think the post-PRK AIDS needs genetic treatment? Because post-PRK AIDS is almost nil due to mitomycin use.
I'm sorry, tell me that again.
The post-PRK AIDS
Yes.
is almost not there after use of mitomycin.
Yes, and again, you could use mitomycin for Haze, but again, it's a big gun, right? It kills the keratocytes, it causes apoptosis, and it causes prevention of healing, and there are long-term side effects. Whereas if you target the CTGF independently, the thinking is that you won't have other off-target effects that could cause weakening of the cornea or prevention of epithelium healing. So it's thought to be a little bit more targeted and maybe avoid the risk of mitomycin.